Reappraising AIDS in Africa. Underdevelopment and Racial Stereotypes. By Charles L. Geshekter. Reappraising AIDS. September/October 1997. The problem with the truth is that it is mainly uncomfortable and often dull. H. L. Mencken. Millions of Africans have long suffered from severe weight loss, chronic diarrhea, fever, and persistent coughs. In 1985, Western researchers suddenly defined this cluster of symptoms as a distinct syndrome, AIDS, and declared that it was caused by a single virus, HIV, which they considered to be sexually contagious. American health officials universally accept this HIV/AIDS model to explain what used to be considered the diseases of rampant poverty in Africa. There are at least 3 reasons why this view needs careful reconsideration. First is the fact that many of the Africans who qualify for AIDS diagnosis, perhaps as many as 70%, turn out to be negative when tested for HIV. Second is the failure of the African HIV/AIDS model to predict the course of AIDS in the United States. Since AIDS symptoms are widespread in the general African population, if it transmits heterosexually, it should also become widespread in other general populations, such as Americans, in which hundreds of thousands of heterosexuals annually contract venereal diseases. Instead, 16 years after it was first described in the medical literature, in the United States AIDS has remained rigidly confined to special risk groups. Of the 70,000 annual American AIDS patients, at least 90% are drug users, including nearly all the gay patients, and fewer than 10,000 are designated as heterosexual cases. Third, sexual transmission can't explain the differences in rates of HIV positivity between African, about 5 per 100, and American, about 1 per 7,000 heterosexuals. When the HIV/AIDS paradigm made its debut in 1984, its proponents assumed that HIV was easily transmitted coitally. Scientists tested this idea only years later, though, when they arrived at extremely low coital transmission frequencies. The latest study shows that an HIV-negative woman converts to positive on average only after 1,000 unprotected contacts with a positive man, and a negative man becomes positive on average only after 8,000 contacts with a positive woman. These data suggest 2 mutually exclusive conclusions. Either HIV isn't a sexually transmitted microbe after all, and other factors account for HIV prevalence, or African heterosexuals are wildly more promiscuous than American heterosexuals, a scenario that surely is not true. With all of this in mind, why do so many health professionals consider it useful or necessary to view the diseases of poverty in Africa as sexually contagious? And why did they ever believe it? Defining AIDS in Africa, CDC physicians Joseph McCormick and Susan Fisher-Hawk convened the WHO conference in the Central African Republic in 1985 that produced the Bangui definition of AIDS in Africa. The CDC had just adopted the HIV/AIDS model to explain the diseases of American drug injectors, a cohort of promiscuous urban gays in the party drug scene, and transfusion recipients. HIV turned out to be one of the many viruses that tended to react with blood from these patients. The same was true of blood from Africans afflicted with the diseases of poverty. The HIV/AIDS model assumed that AIDS would spread via HIV to a much larger fraction of Africans than those who currently suffered from it. McCormick and Fisher-Hawk accepted this model. They recently explained their motivation for the conference, and the rationale behind the AIDS definition that resulted from it. We still had an urgent need to begin to estimate the size of the AIDS problem in Africa, but we had a peculiar problem with AIDS. Few AIDS cases in Africa receive any medical care at all. No diagnostic tests suited to widespread use yet existed. In the absence of any of these markers, e.g., diagnostic T4/T8 white cell tests, we needed a clinical case definition, a set of guidelines a clinician could follow in order to decide whether a certain person had AIDS or not. If we could get everyone at the WHO meeting in Bangui to agree on a single simple definition of what an AIDS case was in Africa, then, imperfect as the definition might be, we could actually start to count the cases, and we would all be counting roughly the same thing, emphasis added. The definition was reached by consensus, based mostly on the delegates' experience in treating AIDS patients. It has proven a useful tool in determining the extent of the AIDS epidemic in Africa, especially in areas where no testing is available. Its major components were prolonged fevers for a month or more, weight loss of 10% or greater, and prolonged diarrhea. The doctors wanted to refute the ugly moralism of the 1980s, that AIDS was a gay plague, by convincing the American government that AIDS was a plague all right, but that no one was immune. McCormick and Fisher-Hawk recalled that experts in STDs continued to regale us with tales of the excessive and often bizarre sexual practices associated with HIV in the West. We were also beginning to see a direct correlation between the number of sexual partners and the rate of infection. Compared to the West, heterosexual contacts in Africa are frequent and relatively free of social constraints. At least for the men, there was every reason to believe that, having found heterosexually transmitted AIDS in Kinshasa, we were likely to find it everywhere else in the world. It was upon these grossly unscientific claims, inaccurate clinical generalizations, Western notions of sexual morality, and 19th-century racist stereotypes about Africans, that AIDS became a disease by definition. Africa was assigned a central role in promoting the premise that AIDS was everywhere and everyone was at risk. By 1986, people were falling over one another to get involved in AIDS research, recalled the couple. They realized that AIDS represented an opportunity for grant money, training, and the possibility of professional advancement. A certain bandwagon mentality took hold. Careers and reputations were riding on the outcome. As proof that these AIDS symptoms were sexually transmitted, McCormick and Fisher-Hawk point to a narrow survey conducted by Kevin Decock, another CDC epidemiologist. In 1986, Decock examined stored blood samples taken in 1976 for Ebola virus testing of 600 residents of the small town of Yambuku, in northern Zaire. Samples from 5 patients, 0.8%, tested positive for HIV antibodies. Decock wanted to know what happened to those 5 people during the intervening 10 years. According to McCormick and Fisher-Hawk, 3 of the 5, 60%, were dead. To determine if their deaths were attributable to AIDS, Kevin interviewed people who had known them. The friends and relatives of the deceased described an illness marked by severe weight loss and other ailments that left little doubt in Kevin's mind that they had succumbed to AIDS, emphasis added. Decock concluded from these interviews that the dead subjects died from AIDS, and that HIV had caused it. He reached this conclusion without properly matching the 5 HIV-positive patients with peers from among the 595 HIV-negative subjects, and without collecting mortality data and morbidity information about them as well. Had he done this, perhaps he would have discovered that even HIV-negative Africans die of severe weight loss and other so-called AIDS conditions. Decock further noted that antibody tests conducted in 1986 showed that the HIV prevalence in Yambuku had remained constant at 0.8% during the 10 years since 1976. As far as he was concerned, this meant that HIV, and thus AIDS, really did originate in Africa. HIV/AIDS existed for years in small numbers of rural inhabitants, who had contracted the HIV from primates, he imagined. He speculated that once some of those people in the late 70s migrated to what Decock falsely assumed were sex-crazed cities, an epidemic of HIV and AIDS exploded. Decock did not consider that these same data could have been